right. Well, David, thanks so much for joining us today for this episode of the Corporate Counterculture podcast. It's really a podcast centered around people who are revolutionaries in their field, and you absolutely fit the bill. So David Contorno is the CEO and founder of EPowered Benefits, a benefits consulting firm that has a very unique and different approach centered around complete pricing transparency, which I'm going to let him cover a lot more about just how rare that is and the stories behind it. But was fascinating to me. I had the pleasure of attending a coffee break that he and his coworker Emma host, and his candor, your approach as a disruptor, and your willingness to speak out against the things that bother you and come up with solutions to change were really what caught my attention. I'm very excited and grateful to have you as a guest today.
Thank you for having me.
Yeah, my pleasure. So I wanted to get started asking you, we'll get into more of the stories in a bit, but just tell me anything else about yourself and the EPowered Benefits brand. Kind of what do you guys do, and a little bit about yourselves.
Sure. Well, first, a little bit of history. I've been what most people would describe as a health insurance broker, which means I've been helping employers manage their healthcare costs for 27 or 28 years now, since I was 17 years old. So I fit the traditional role for many years, but I came to a couple of realizations about 9 or 10 years ago. The first was that not a single one of my clients looks forward to meeting with me because I'm bringing in varying degrees of bad news every single year. The second thing was, what got really hard for me was not the meeting with the employer, the one that actually decided if I got the business or not, because that employer was similar to me. They drove in nice cars and they wore a nice suit and they were sitting around a very expensive conference table, just like I was. What got really hard was a few weeks after that meeting with the employee, and I told them essentially what the effect was of the decisions that we made at that table. And it was always some degree of what's coming out of your paycheck is going up, and simultaneously what's coming out of your pocket when you actually use the plan is also going up. And when I started in the business and it was a $100 premium and a $100 deductible, a 10% increase wasn't that big of a deal. But when you're talking about $2,000 family premiums and sometimes $10,000 or $20,000 out of pockets, a 10% increase is pretty painful on an already painful number. So what changed my path was when I started to ask questions as to why this is happening. And part of why I was confused was because most people in the US think the healthcare system works very differently than it did. And I thought at the time that the healthcare system was also being harmed by a lot of these things. But that's actually not true. And when I dug in and I started to find out how people make money, where they make money, when they make money, it all became really, really clear.
Yeah, I am excited to get into this part and to just add a little bit of my personal background, like where I started. I haven't done the extensive research that you have. I have a lot of personal stories around it and just aha moments. And I'm a bit of a questioner. So when I see a problem and I have questions around it, I will go do research and figure out what it means to me. And one was my family, my mother lived in a very small town in the North Carolina mountains that is kind of weirdly 1,200 people and weirdly just have or have nots. It's like a slice of life there. Okay. And she always used to laugh and say by default, she was the have. She was like, I am the least have of the haves, but that's who I hang out with. And in spending time visiting her and going to some of these families, lovely people, wonderful people who welcomed me into their homes and beautiful homes, but the degree of wealth, and again, good on them for working that hard and having it, but they were, an example would be the family whose house I went to for a Christmas party listed their home, and the first two people to look at it were Bruce Springsteen, followed by Julio Iglesias. So that's the level of wealth. And when I asked them what they had done, they were retired and had private jets and homes on private islands and very expensive horses that they showed competitively. It was an insurance company executive, and there was quite a few of them in that town that were on par with some of the most well-known celebrities in the world in terms of wealth accumulation. So that was a big part of what kind of started me really looking into this outside of my own personal health journey, really looking into this and saying, what's going on here? I'm excited to hear your perspective, though, having done a lot more research on the user end. So is there anything else you want to add about your why, your inspiration for launching EPowered Benefits before we dig into some of your findings?
Yeah. Yeah, so the problem and the reason that I really had to make a clean break was because prior to founding EPowered Benefits, I owned another insurance agency in a more traditional vein. And I was trying to transition, but let me tell you some of the conversations that occurred. The executives of Blue Cross and Blue Shield of North Carolina would come to my office and say, David, if you don't bring up your closing ratio, we're going to cut your contract.
Mhm.
Now, you understand that cutting my contract wouldn't only prohibit me from doing future business with Blue Cross and Blue Shield, the largest carrier in the state I live in,
Mhm.
but I had about a $2.5 million agency, of which about $1 million coming in was from Blue Cross and Blue Shield. I would lose that too. And I'd have to literally, not only would I lose a third of my revenue overnight, but it would cripple me from a competitive standpoint to quote unquote not have Blue Cross. Or United Healthcare would call me up and say, David, if one more group leaves us, your $250,000 bonus that you're going to get at the end of the year is going to go to zero.
Mhm.
So, but the problem is, and I'm going to explain why through the course of this conversation, they're never going to embrace strategies that improve outcomes or lower costs. They literally can't, because it would violate the only fiduciary responsibility they have, which is to their shareholders. And I'm going to tell you exactly why that is. So when I started to realize these things, I realized that when we turn these incentives around, we can do it, but I had to make a clean break. And so founding EPowered Benefits allowed me to have 100% of our revenue for consulting on health plans come from one place and one place only, and that is the client. See, I believe that everybody works for whoever it is that is signing their paycheck. And when you're getting paid commission by Blue Cross and Blue Shield or United or Cigna or Aetna, they are the ones signing your paycheck and you work. And I'm not saying that any broker out there, although there are some, there's always bad apples, are going to intentionally put plans in front of you that are going to cost you more. But I am saying that they're not going to search for all the available solutions when the gravy train is the one that's already in place. And there's a great Upton Sinclair quote. I'm probably going to, not say it verbatim, but it's along the lines of, do not expect a man to understand something in which his paycheck is dependent upon him not understanding it. So the first thing I changed was how we get paid, and I had to make a clean break. So, and I'll talk more about that as we go through, but aligning the incentives so that the employer, who's the payer of healthcare, and by the way, and with the patient, of course, as well, but a lot of people in the industry, especially hospital administrators, they call the carriers the payers. And I think that that's a damaging psychological position, because when a doctor or hospital thinks that the insurance company is paying the bill, they don't care about the financial devastation that they're about to unleash. But we know not only has more of the onus been put on us because of deductibles and out-of-pockets that go up, but the more our health plan pays out this year, the more it's going to cost us next year. So just saying an insurance company pays for anything is about as accurate as saying that my accountant pays my taxes. He just tells me what to pay and how much to pay and whom to pay, but he doesn't pay for anything. And neither do insurance companies. They don't pay for anything. They're passed through 100%. That's why you get renewal increases every year if you're fully insured. You see it a little more directly if your plan is self-insured.
Yeah, it just reminds me of like the old adage, put your own oxygen mask on first. Everybody's going to help themselves before they. I think I believe in the goodness of people. I believe there's tons of people out there who want to help. But if you say, "Hey, help me," and it impacts you financially, well, the average person doesn't lead with that much empathy where you're going to, nor should we really put other people above yourself. You should put yourself first and then seek to help others. But the system is just really broken that it doesn't really allow for that. And I see it partially as, one of the industries, and it certainly is affecting more than just the insurance, but kind of contributing to the great resignation, like the soul sucking, that eventually, if you are a good person and seek to, of course, have a great life for yourself, but also help others in the community, that can take a real toll on you when you're treating people as a number from the hospital. There's a patient and you don't think about them as a human being and their life and what may be going on behind the scenes and what a hardship this medical challenge is on them. You're really just thinking, oh, the payer. provider, the insurance company, is going to pay this bill. And it's a real disservice to humanity. So I'd love to hear a little bit more from you kind of about the things that you've uncovered in your research, about the things that made you step back and say, wow, this is so broken. I have to do something to change, and really motivated you enough to go start from scratch and make a clean break from your previous enterprise.
Sure. Well, one of the things that really opened my eyes to some of the dysfunction was an unintended consequence of the Affordable Care Act, Obamacare, PPACA. I'm going to call it the Affordable Care Act, or the ACA. And it's a provision of the ACA called the medical loss ratio provision. Mm-hmm. And if there's one thing that, if there's a CFO listening to this, if there's one thing that I can get you to understand, it's this. Mm-hmm. Most people think, CFOs especially, that insurance companies make more profit by denying claims, by lowering claims, by negotiating better contracts with hospitals and doctors. And that is 100% not true. See, the medical loss ratio provision says that every insurance company must spend 80 to 85 cents of every dollar. And the reason it's 2 is because it's 80% if they are a small group, which is typically defined as under 50 employees, although some states it's under 100. And it's 85-15 if they're a large group, which is over 50 or 100. So let's talk about the 85-15, because that's more applicable, but it works the same either way. So I am able to keep, if I'm the insurance company, I'm able to keep 15% of the premium that I collect, and medical costs must be 85% of that premium. So if I reduced claims by denying claims, by negotiating better contracts with hospitals or doctors, I would reduce the premium, which would reduce my revenue, which would also reduce my profit. And as most of you know, I would think that most insurance companies are publicly traded companies, and their sole responsibility is to their shareholders to do what? Drive as much profit as they possibly can. So if you guys want to know, if anyone wants to know why healthcare costs on average go up 10 to 20%, I'll tell it to you right now. Every doctor or hospital that is quote unquote in network with your plan, in network just means there's a contract. Now, I encourage anyone, especially if you're self-funded employer, to ask your insurance company, hey, you know the contract that drives my actual cost for care? I'd like to put my eyes on that, please. And I promise you, they're going to say, I'm sorry, that's proprietary and confidential. We can't share that with you. But let me tell you what's in that contract. There's a few things that would concern you. Number one, there's typically no audit clauses or some sort of audit prohibition. So again, I don't want to get too much in the weeds, but hospitals, for example, they bill an insurance plan on a form called a UB4. You can Google it, UB04. Mm-hmm. Every hospital, every facility bills on it. And if you go in for open heart surgery, there might only be 4 or 5 line items on there. It'll say the hospital charges, the surgical charges, the pharmacy charges, the lab charges. It'll have a dollar amount tied to that. And when that claim comes in, most insurance companies are unincented to do anything on that bill, but also prohibited contractually from auditing that bill, at least to some degree. And it differs by facility. It might be you can't audit until you pay us. That was one I know that Baylor Hospital had at one point with Cigna back in the day. I don't know if it's still true, but or sometimes you can't audit at all. So now the government estimates that 97% of hospital bills have errors. And I'm using my air quotes because I think it's disingenuous to call it an error when it's always in the favor of the provider. Mm-hmm. If it were truly an error, it'd be 50-50, maybe 60-40, but it's not. It's always in the favor of the provider. So the first problem in that contract is there's audit prohibition clauses. Problem number 2 is that there's anti-steerage clauses. You see, we're probably reaching people around the country, but I want everyone to think for a minute who the local big health system is. Every area has one. Yeah. So think of that name in your head. Now, I want you to think if your company that you work for left Blue Cross and Blue Shield, do you think that that insurance company's balance sheet would be dinged even a little bit? No, there's not one employer that can pull away from these large insurance companies and have a substantial impact. Okay. But what would happen if that local health system left the network of that carrier? Then they're going to lose every employer in that market. I can't have a plan that doesn't let my employees go to Mayo Clinic, Cleveland Clinic, Memorial Sloan Kettering, Cedar Sinai, you name it. So remember, I said before, the insurance companies benefit from rising costs. Who else benefits from rising costs? The hospital.
Mhm.
So think about this for a second, people. Your hospital and your insurance company are going into a closed room, backdoor room, totally shrouded in non-disclosure everywhere they can. And they're both, quote unquote, negotiating prices with each other, but they both benefit from pricing going up. So
sounds like a win-win negotiation for them.
right. So one of the things that I realized, and this is another problem with the contract, is that hospital will say, okay, we'll agree to do the favor of being in your network, but number one, there has to be no audit clauses or some sort of audit prohibition. Number two, there is no steerage. So let me explain to you what steerage is. I'm going to demonstrate through this call that higher quality care actually costs not a little less money, a lot less money. And my own hernia surgery, for example, if I went to the local hospital here after the Blue Cross discount, which is what I had at the time, I would have paid my plan would have paid $47,000, of which I would have paid $5,000. But instead, I went to an outpatient surgical center that had a higher volume of hernia surgeries, and they had zero complications, infections, or readmissions, whereas the local hospital had a lower volume of hernia surgeries, higher volume of infections, and they actually had one infection that was a hospital-borne flesh-eating bacteria, and the patient actually died.
Oh.
But this other place, which is called Surgery Center of Oklahoma, they're one of the grandfathers of the transparent movement, they have all their pricing and quality posted on their website. You can go there right now and look. Anyone can go. surgerycenterofok.com. Dr. Keith Smith is the owner. The total all-in price of a hernia surgery there, known up front, because the $47,000 was an estimate. The bundled price at Surgery Center of Oklahoma was $3,060.
Mm-hmm.
So if an employer is footing the cost of care, wouldn't it make sense for them to say something like this? You know, if you go to where the quality is lower and the price is higher, your $5,000 out of pocket applies. But if you go to the $3,000 place where we know the outcomes are better, you're likely to be back at work quicker, be more efficient sooner, we're going to pay 100% of it. Doesn't that make sense?
It does. It seems like an easy solution.
But that's steerage. Right. And so when the Cleveland Clinic contracts with United Healthcare, they say, we'll be in there, but you cannot make it financially beneficial for anyone to go to one of our competitors over us.
Right.
And one other tip, we have access to tons of quality and cost metrics. And I can tell you that almost always the lowest quality, highest cost hospital in your area is the one you think is the highest quality. Most people don't even think about cost. The last thing that's in that contract is the hospital has the right to raise their prices by 9, 10, 12, 14% a year. So if you want to know why your insurance premiums go up 9, 10, 12, or 14% a year on average, it's because the hospitals are allowed to inflate their pricing by that amount in the contract. It benefits the insurance company. It certainly benefits the hospital. That's why they're doing it.
Yeah, I love this. I'm a huge believer if you, in anything in life, if you follow the money trail, the answers will be right there. And with my own health journey, I've had quite a few surgeries. I had a traumatic accident and shattered both my feet, and have had 65 surgeries and procedures related to it, and nearly died several times as well. So I'm no stranger to the healthcare system, and truly grateful for some of the doctors. Like, I wouldn't be able to walk and I wouldn't be alive without the quality of doctors and the care that I've received through the years. But that said, oftentimes it raised some really big questions. As a patient, I just kept asking myself, who does this work for? Who does this work for? And if I'm just one person, but guess what? I was employed at the time and my company was contributing to those benefits. And I am probably one of those people that was driving up overall costs and all of the different issues that we look at, and that you kind of come back and blame me, and fine, put whatever label you want on me. It was my fault. I drove up all the costs with all my surgeries. But my concern was things like, I would go in and just sometimes there's a little hiccup with insurance or how you're getting admitted. A bill wasn't run through insurance and I received it and it was a bill for $1,100 and it was a very quick, easy visit to the hospital. But, by stretch of, I've had months of stays there. So in comparison to that, very easy. I called them and let them know, could you run this through my insurance provider? It's not going to make a dent. It won't cover my deductible. However, I'm expecting some more treatment and I want to make sure it counts towards my total out of pocket for the year. Mm-hmm. Mm-hmm. And I think that's how you're trained to think about as a patient and as an employee. That's how you're trained to think about it. So they did so, and I got the bill back quite some time later. And that same $1,100 visit was now $13,700. But due to the wonderful discounts that traditional insurance carriers are providing, I only owed $4,400. So only 4 times as much as had I walked in off the street and just gotten the exact same treatment from the same people that I received. I'd love to hear a little bit more about your stories. If there was any aha moments where you just stopped and were like, and along the way, I know we kind of got into that, but if there was anything that was one thing that stands out at you where you just said, this is so corrupt, I don't know what to do next. Do you have that kind of one thing to go to?
I do. And it's on the pharmacy side of the house.
Okay.
So let's pick on the PBMs a little bit. We picked
All
on
right,
the
let's do it.
So there's 3 pharmacy benefit managers in the US that control about 85% of the commercial pharmacy market. One is called Express Scripts, which recently got purchased by Cigna. The other is called Caremark, which is owned by CVS and purchased Aetna. And the third is called Optum, which is owned by United Healthcare. Now, the problem with insurance companies owning PBMs is this. They can do things, 2 of which I'm going to tell you in a minute, to increase costs and maximize profit. And PBMs are not held to a medical loss ratio. So they can take 90% profit if they want. And the more they bring drug pricing up, the more money they make. And the more they bring drug pricing up, the more it inflates the loss ratio on the fully insured side of the house. Mm-hmm. So it's beneficial for them in many ways. And there's an interesting statistic about Express Scripts. Now, you need to understand that a PBM does not make medication. They don't research medication. They don't deliver medication. They don't pay for medication. They don't prescribe medication. All that they do is process a transaction within your health plan. That's all that they do. Now, for anyone that's a business owner on this call, I want you to think for a minute about the total revenue of your, divide that number by the average number of employees that you have currently. And that's just going to give you revenue per employee. Most companies in the US are thrilled to have $250 to $450, maybe $500,000 revenue for employee. That's different in different industries, but overall, that gives them money to pay the employee, pay their benefits, pay their overhead, and still have money left over for profit. Express Scripts revenue per employee is $2.7 million. Now, I want to put that into context. Imagine if the maker of aircraft tires, all they do is make tires for airplanes, but they were 10 times larger than Boeing. That would seem odd, right? That's what we have here. We have these PBMs. Express Scripts is like on its own, like in the top 10 largest companies in the United States. So they're bigger than most of the drug makers. It's insane. So let me tell you 2 techniques that they use to maximize their profit. Now, you need to understand that employers are paying an admin fee, and most employers think that that's all they're paying. But the number one source of revenue for these PBMs is something called spread pricing. And you can Google it, I encourage you to. But basically, when an employer signs a PBM contract, there is methodology in there that determines what the plan is going to pay for a drug. And that's typically a methodology that's known as a discount off of something called average wholesale price. So there's a running metric of average wholesale price in the US. It changes daily. And your PBM contract says that they're going to guarantee at least an 80% discount, let's say, off of generic drugs. Okay. So let's pretend that an employee of a plan goes to pick up a drug. It's a generic drug. The wholesale price is $100. So the 80% discount brings that to $20. And let's pretend that the member has a $10 copay for the generic drug. So the member goes to the pharmacy, they pick the drug up, they pay their $10. The plan gets the claim a few days later, and it says this: the drug cost was $100 wholesale, 80% discount is 20. The member paid 10. So the plan owes 10, plus they owe Express Scripts a $4 processing fee. So the total cost of that was $24, of which $10 from the plan for the drug, $10 from the member for the drug. So here's my question. How much do you think the pharmacy gets for that drug? You'd think $20, right? The member paid 10, the plan paid 10, Express Scripts got their $4 for doing their magic.
Yeah.
But when Express Scripts contracts with the pharmacy, they contract on pricing that's a completely different metric. They price it on something called WAC, which stands for wholesale acquisition cost. And what the PBMs have done is they've ensured that whatever discount off of AWP the plan is paying is a higher price than the WAC price. So the average WAC price of a generic drug in the US is about $2.22. So the pharmacy only gets $2.22, but the plan pays $24. And you multiply that by thousands of drugs, generic, and even bigger spread pricing on name brand. But wait, there's one other technique that these PBMs do. And this is what is really harming independent pharmacies. And if you want to know why all the local pharmacies are shutting down, here it is. It's called a clawback. You see, in that very same transaction, the PBM is going to say to the pharmacy, whoa, wait a second. You were paid $10 for something we're only supposed to pay you $2.22 for. So the next drug that Express Scripts fills at that pharmacy, even if it's another plan, another member, it doesn't matter. They're going to say, you were overpaid by the member on that last plan, so we're going to claw back the $7 and change difference. So not only do they not pay the pharmacy a single penny for that drug, they actually take money from the pharmacy. So they overcharge the plan. They got paid a transaction fee on top of that, and then they took money from the pharmacy on top of that.
Sounds like a great deal for them.
It is. It's been good for their shareholders too.
Yeah. I mean, and it's interesting, you know, I'll just kind of lay this out there. We'll continue to move on, but it's just interesting as you speak about pharmacists, again, just using my own stories, because I've had such a journey in the healthcare system and really learned it kind of from the ground up, just by asking questions, and then eventually found myself in the healthcare revolution. But something interesting to me is after my original accident, I was, of course, given antibiotics. I had multiple surgeries in the hospital. And a week later, I was back in the hospital for another week plus. I don't remember completely. I had a C. diff infection, a horrific response to the antibiotics. And come to find out, after 20 years of journey, I have now 2 neurological pain disorders, a blood disorder. I'm in stage 1 kidney failure. My liver goes back and forth, but has been as high as somebody with cirrhosis of the liver. And all of that they have found is related to antibiotics. I had a really severe reaction that poisoned my nervous system and caused a severely debilitating autoimmune condition that has unfortunately led to these. And I'm with tremendous care with holistic doctors and a lot of supportive work and doing better than ever. But that took a real toll, all of those surgeries and that amount of pain. The disease I have is labeled a suicide disease because I can tell you, like, I've sat up at night and was like, do I need to go to the hospital? Because I'm going to cut my foot off. I was like, I know they can't help me and there's nothing they can give you, but I was like, that's a crazy thought. You know, it's that kind of stuff. And I'm fortunate they have a great support system and network and just a happy person in general and have pushed past those things. But I look at the toll that it took. And if it starts with you making that much money, but also giving medication that is further fueling that system and creating that money, it just made me realize this may be even more corrupt than I ever thought. And I told you I like to ask questions. So some of the questions I asked, and my reaction was to Cipro. It's a class of medication that, candidly, I'm not entirely sure how to pronounce. It's a tricky word, but commonly referred to as floxed and spoonies, that community. There's different ways to go about it, but those are the issues. And when I started my own research on it, I found it really odd that doctors speaking out against it were coming up dead. So I was like, what is going on here that there's this much money to be made? You're explaining how it works in the healthcare and medical system and the PBM system. And I'm looking at it as just a person who's trying to get through life and deal with these challenges and be happy and productive in the business world. But I'm asking myself, why are people getting killed over this? And why have I asked 3 different doctors for information about my condition? And their response was, due to licensing concerns, I am unable to answer that question, but I strongly encourage you to do your own research. So I'm early in that research game. I don't have a lot to add here, but again, that raised a really big question for me. And I wanted to share with the audience that do your own research, know what you're getting into, and don't take what we're being told at face value, because it's not always true. Cash is king in most things in life. So follow the money and ask good questions.
Well, and I think that that is a good segue into another part of the healthcare system that's really broken, and it's doctors' compensation. Most doctors that work for a large health system, their compensation is impacted by several factors, but one of them, and I encourage you to ask your doctor, you'll blow them away that you even know this, but ask them, hey doctor, do you get paid on RVUs? And an RVU stands for relative value unit. And it's a measurement of how much revenue that doctor is helping generate in other parts of the healthcare system. So if I'm a primary care doctor, for example, the other part that impacts my pay is the volume of patients. The more patients I see, the more money I make. The problem with more patients I see in a day, it means I see less time per patient. So the quality of my care goes down quite substantially. And I believe in the US, the average primary care visit is a 21-day wait, and it's 7 minutes with the doctor is the average. So let's pretend that I go into my primary care doctor with my back hurting. Well, because he needs to see so many patients, his most profitable path by far is to write me a script for a pain medication like an opioid. And many of you probably know we have an opioid epidemic in this country, the large majority of which started with a legitimate prescription taken exactly as prescribed and paid for by their employer's health plan. So I write that patient a pain medication, and then I refer him to my buddy, the back surgeon. Now, when you go to a back surgeon, what do you think the most likely outcome is going to be?
You need back surgery.
Right. To a hammer, everything looks like a nail. To a back surgeon, everything looks like back surgery. Well, by referring you to that back surgeon and you getting back surgery, that primary care doctor has maximized his or her revenue. And you've gone to the place where the most interventional, most expensive care is most likely to occur. And by the way, statistically speaking, the most likely outcome of back surgery is another back surgery. So why they're not going to send you to physical therapy or chiropractic or maybe a steroid injection, they're going to go to the highest cost intervention. So remember, we talked about the broker early on, how average broker gets commission, which means as an employer rates go up, how much money they make goes up. The insurance company, as claims go up, premiums go up. As premium goes up, profit goes up. So as your costs go up, they make more money. The PBMs make more money as more drugs get filled. The drug companies get paid as more drugs get filled. The local doctors and hospitals make more money as costs go up and more claims get paid. Your costs keep going up every year. It's because every entity that an employer trusts to help manage their healthcare costs makes more money as costs go up. And one way, by the way, for costs to go up, and this is really clear if you can look at the quality of our healthcare system over the past few decades, but one way to increase costs is to lower quality. And I'm not saying that any doctor or hospital is intentionally doing low quality work, but think about it from this perspective. Let's pretend that I'm a hospital administrator and I realize that we need some new infection control device, whatever. So I have my minions go out and get a bunch of RFPs, and I said, just bring me back the lowest and the highest. That's all I want to see. So one's $1 million, one's 100,000. Maybe the $1 million one is 99% effective. The $100,000 one is 97% effective. So I'm like, okay, by getting the $100,000 one, I'm going to save 900,000 now. And if my readmissions uptick a little bit, I'm going to make more money then too. So like, I think it's not any hospital administrator or even doctor intentionally making decisions that lower. I think it's hundreds or maybe thousands of little decisions every day that collectively add up. And for those of you that don't understand how low quality our healthcare system is, let me give you some statistics. The World Health Organization ranks our system 37th on quality. We're tied with Slovenia. There's not a single industrialized nation that ranks lower than us, and there are third world nations that rank higher than us. I mean, here's a statistic. Before COVID, preventable medical errors was estimated to kill 600,000 people in the US every year. Imagine if 600,000 people died every year in airplane crashes. Nobody would fly, but we go into hospitals all the time, every day. So If you want to know why you're getting the results you're getting, it's because all the entities that you trust to give you different results benefit from the results that you're getting.
Right. And not making it any better. Why would anybody want to solve something that is padding their pocketbooks? It's never going to be fixed until the demand for change comes there. So, and speaking of that demand for change, I wanted to shift gears a little bit into some stories and experiences with brands and companies and employers that you've helped. But I do want to give you the opportunity. Is there anything else that you'd like to kind of highlight about the research that you've done, what's broken and why before we make that transition?
I really want employers to start asking different questions. And you mentioned at the beginning that you think I'm revolutionary or innovative. I tell people all the time that I learned everything I need to learn to fix healthcare by 9th grade economics class. Like, all you need to do is look. And what frustrates me is there's a lot of really, really smart business owners that have put the resources into expenses that are much lower down on their P&L list into managing that expense. And even yesterday, I was on the phone with a hospital, because I want you to know hospitals are some of the worst at managing their own healthcare costs for their own employees. Okay. Yep. I'm on the phone with the hospital, and he starts off at the beginning of the call by, and this is a rural safety net hospital, many of which are in real financial trouble right now. And he says to me, if we don't lower our healthcare costs, we are going to shut our doors. That's how he started the conversation. The end of the conversation was, I don't know, that sounds really different and disruptive. I'm not really sure we're ready for that. I'm like, dude, you just told me you're going to shut your doors. Like, and this is not disruptive. The reason people think it's disruptive is that we intermingle the words healthcare and health insurance in our vernacular as though they're one word. I ask people all the time, who's your healthcare provider? And the number one answer I get is Blue Cross and Blue Shield. Let me wake everybody up on this who's listening to this. Blue Cross does not provide any care at all, period, zero. Right. Your doctor provides care. Your hospital provides care. Your nurse, your pharmacist. Saying that Blue Cross provides care is like saying Geico provides cars. They don't. So if everyone can understand how brokers are paid, and I encourage you, I'm actually wearing a shirt here that's a nonprofit organization I'm part of called Health Rosetta. And if you go to healthrosetta.org, you can download a compensation disclosure form for free. Ask your broker to have an executive at their agency fill it out and sign it. I promise you most won't, especially the large brokers. And I want you to know, the larger the hospital system, the lower quality care, the higher the cost. The larger the broker, the lower quality advice you're getting, the higher the cost. The larger the carrier, the lower quality care your employees are consuming, the higher the cost. I mean, it is almost in that order every single time. So if employers could start to ask, who's making money, where, when, and why, I want to know my costs before they occur, just like they know their office supply costs, their automobile costs, everything else. And if they started to ask those questions, I think I'm surprised by the answers they get, or I think they should be even more surprised by the answers they don't get.
Yeah, those are fantastic questions. And it just begs the question, like, that's not disruptive. It just makes sense. But I feel like that's really kind of, we've all got the wool over our eyes, or as a society, not all of us, but there's just the wool over our eyes. It's like, well, we do it this way because we've always done it that way. I'm like, but it's terribly broken. So why would you not change? Like, if you want to get in shape and you're finding yourself eating cake in front of the TV every night and skipping workouts and saying, I'll do it tomorrow and I'll start tomorrow, it's not super effective. More power to you, your choice. But the same thing with this, people like, well, I can't do that because, it's just, I've always done it this way. I'm just going to do X, Y, Z. It's so silly. Any results that are really motivating to you typically take some work and discipline to develop the habit and make that change. I feel like as a society, we've become really change resistant to our own detriment, and companies are failing as a result and employees are suffering. And I just kind of want everybody to shake and be like, wake up. And, it's easy to do things differently. And in many cases, it actually saves you a lot of money, which is what I want you to get into now. Yep. I'd love to hear any of your favorite customer experience stories that you can share with the audience. Kind of talk about what impact has working with EPowered benefits had.
Yeah, so we don't focus just on financial, but we also focus on clinical. One of our core beliefs is that if you can get people the right care at the right time, at the right place, by the right provider, that in and of itself is going to lower costs, as well as lowering costs. And a lot of people question, wait, higher quality care costs less money? And I'll tell you the metric that influences that the most. It's frequency. the more frequently a doctor and hospital do a particular procedure, surprise, surprise, the better they do it, the lower the cost. So I'll give you an example in orthopedics. You want to go to an orthopedic specialty surgical center, outpatient surgical center. Why? Because all they do is orthopedics. From janitor all the way up to hospital administrator, all they do is orthopedics. So they don't have emergency departments. They turn patients away when they're sick. So you don't have people coming in with pneumonia and COVID like you do at the general hospital. But here's the problem. If I'm an orthopod and I admit at the local surgical center and the local hospital, I am going to get paid more if I do it at the hospital. Even though the outcomes are worse, the infections are higher, the mistakes are more, but the price difference, and we're not talking like a 10% reduction. We're talking usually it's 3, 4, 5, 800% more to go to the hospital. Mm-hmm. So here's a few stories. We took over a plan. It was a county, a municipal plan. And we identified that there was a spouse of an employee who was a high cost claimant. She was undergoing cancer treatment and she was getting a cancer infusion, a chemo infusion that was costing $100,000 a month. She had been taking it for 18 months. So as many of you are aware, treatments like that require medical management. They require a doctor to call the insurance company and get permission. They call it pre-certification or prior authorization. And the reason that was done, by the way, was because 30 or 40 years ago, when our health system turned to a fee-for-service model, doctors started to do more services because that meant more fees. And they were doing a lot of unnecessary tests and procedures and prescriptions. So medical management initially was designed to push back against that. But it's been perverted to now where the insurance companies use it as a way to drive people to where it benefits the insurance company the most. And the best evidence of this was there was an Aetna exec that when they retired or quit, they became a whistleblower. And they showed the court documents that said that 97% of Aetna's decisions on what to approve and not approve in their medical management was being made by people that had absolutely no clinical training whatsoever, and they weren't even looking at any clinical notes. So it's really important that you put in proper medical management that has evidence-based guidelines on clinical care that can say, wait, we had 1,000 people like you. We know exactly what the best outcome is likely to be and what path you should be on for that. That's really important. But so our medical management vendor calls up this oncologist a couple of months before the new plan was going to go live. And they said, and I listened to the recording of the call, but it basically went like this. The nurse oncologist said to the prescribing doctor, hey, doc, we're getting ready to take over the medical management of this plan in a couple of years. We see you're treating patient ABC. Both the drug manufacturer and the FDA say that clinically certain pathology must exist to indicate that this is both the proper diagnosis and the proper treatment. Can you please send us the lab slips from 18 months ago showing that you did the test necessary to indicate that this is the right diagnosis and treatment? The doctor's answer was, I've been an oncologist for 25 years. I've seen this type of cancer thousands of times. I know exactly what it is and exactly how to treat it. And the nurse said, well, doc, we sincerely hope you're right, but we're not paying for it unless you do the tests come January 1st. So he was back against the wall. They do the tests. She didn't have the type of cancer he thought she had. She had a completely different type of cancer. And the type of cancer she had, the best treatment was only $10,000 a month, so it's 10% of the cost. And in the 18 months she had been on the other treatment, surprise, surprise, her tumor had not shrunk at all. In 9 months of on the different treatment, her tumor had shrunk by 75%. So not only did we save the employer 90%, now why was a doctor even leaning towards infusing a drug that expensive? I'll tell you why. Because doctors that do infusions get paid a 6% markup on the cost of the infusion. So even if there was a $100,000 one and a $10,000 one, both of which were truly clinically appropriate, they're going to gravitate towards the higher cost one. Right. That's always going to happen. So that's one story. Here's another story. We had a member who we come to find out is trying to get a back surgery at the Cleveland Clinic. Now, the Cleveland Clinic is really good at a few things. They're really bad at a lot of things, and most people don't know that. So this patient is trying to go to Cleveland Clinic. Now, one of the features of our plan that is both a positive and a negative is that our plans don't have any network of providers. You can go to any provider you wish to go to. Now, we help steer you and incentivize you to where we know the quality is high and the cost is at least fair and transparent and known in advance. But The Cleveland Clinic said, well, we're not going to do this surgery unless we get a $71,000 deposit, and then we'll bill the rest. We don't know what it's going to be. Well, that seemed really egregious to me. So I start doing some research, and I come to find out he's not having a back surgery. He's having a corrective back surgery with the same surgeon at the same facility that did the first one. Well, I find that out, and I'm like, I don't want him going back to the same place that screwed him up to begin with. So we do some research, and we come across Dr. Richard Kuby, who owns his own surgical center called Prairie Back and Spine in Peoria, Illinois. Mm-hmm. And he specializes in correcting other back surgeons' mistakes. And he gave us an upfront, all-in bundled price of $21,000. So I was able to call this member up. Now, this was a Friday afternoon, and if we didn't get this settled by the end of the day, they were going to cancel the surgery that was currently scheduled for Tuesday morning. So I was actually able to call Dr. Kuby on his cell phone, had him call the patient on a Friday, like 6 p.m., and have a conversation with him and make the patient feel at ease. And the patient agreed to go to this other facility. And we said, great, we're going to pay 100% of it, your health plan, because you're doing the right thing. You're saving the plan money. You're going to where the outcomes are better. And so we waive out of pockets on medications, surgeries, x-rays, MRIs, you name it, when members allow us to steer them to where the quality is high and the costs are low. And if they don't let us do that, then because the plan is set up differently and pays for care differently, we still save the employer a ton of money, but we typically put similar out of pockets to what they're used to if they just kind of go wherever they want to go. So no harm, no foul if you keep going, but much better outcomes and much lower out of pockets if you allow us to bring you somewhere else. And back to the orthopedic surgery for a minute, sometimes it's just saying to the orthopod, we will only do it at the orthopedic surgery center. And we actually tell them the plan won't pay for it at the hospital. So now we get that person's doctor to do it at the place where the outcomes are the best. That's assuming they're a good doctor, but that's another fallacy. Everyone thinks their doctor is good. I've been on the planes, hundreds of plane rides, and I get in conversations with people, and everyone has orthopedic surgery, and everyone thinks that their surgeon was the one that does the local sports team. It's not true, guys. It's just not. And there's a fantastic book. It's actually right here, and it's by a doctor named Dr. Marty McCary, and it's called The Price We Pay. And this talks about things that all doctors say to induce the patient to do what they want them to do. And one things that orthopods say all the time to patients is, oh my gosh, your knee is bone on bone. There's no such thing as bone on bone. You might have not as much cartilage, but you can't have bone on bone. It's physically impossible. But they say that because then it makes your teeth like fingernails down a chalkboard. And you're like, oh my God, I got to fix that right away, whatever it takes, doc. So they do, this is what the system does. The system doesn't want you healthy. It's getting healthy for the lowest cost, the fastest path possible. The system wants the opposite. And I know a lot of healthcare providers and even some insurance companies are quote unquote nonprofit. Let me tell you guys, they are some of the most profitable entities in the country. And just because they're nonprofit doesn't mean they don't serve to make as much profit as possible. What it means is that they're not paying any taxes. They're being subsidized by you and your employees.
Yeah, that is so eye-opening. Thanks, David. I'm kind of blown away, and I'm just laughing because as you're talking, yes, two of my foot orthopedic surgeons both worked for did the local soccer team. So I'm like, oh, I'm recognizing myself in here. Yep. Switching gears again a little bit, and we'll circle around. But love to ask, what are a few accomplishments that you're most grateful for along your own journey?
Well, so I talked a little bit about how brokers are compensated. So let's just talk about how we're compensated because I'm proud of it. We charge our clients a flat fee. And with most of our clients, so I liked getting bonuses. Like I liked getting a big check. Who doesn't, right? Sure. But I didn't like what I had to do to get it when it was United or Blue Cross or Cigna giving it to me. So now we create bonus structures with our clients, mutually agreed upon bonus structures. And they can tie it to whatever metric they want, but the most common one that employers tie it to is lowering costs. And we've gotten some really big bonus checks, but it's only a little fraction of what we save the employer. So what kind of savings are we talking about? Now, for those of you that don't have P&L visibility in a company, I want you to understand that for most companies, this is like number 2, 3, 4, or 5 on the P&L. Like this is next to payroll and maybe the cost of goods if you're a manufacturer, like this is the next biggest expense. So this is huge. Average, just ballpark numbers, the average employer is spending about $800,000 to $1 million per 100 employees that they employ on the plan. Okay, so on average, we lower healthcare costs by 20 to 40% at the end of the first year, and typically another 10 to 20% at the end of the second year. And then once we get all the excess out of the system, once we get employees going to higher quality providers and more transparent providers, once we have the right pharmacy benefit manager, and I want you to know too, we do other things on pharmacy like international importation of drugs. Or one of the things I love, and I love turning this around on the drug companies, but if you guys, I'm sure everyone has heard a drug commercial. It's interesting. There's only 2 countries in the world that even allow direct to consumer drug price commercials. It's us and New Zealand. But at the end of a drug commercial, it says, if you cannot afford your medication, AstraZeneca, maybe it'll help. And they say it really fast and really low. And what they're advertising there is something called the Patients Assistance Program. Now, this came about back when Medicare Part D was signed into law under George Bush II, because overnight, not only did the US become the largest buyer of drugs when we first gave drug coverage to seniors, but it's set in the law that the price we pay, which is about 4 to 5 times more than what most other governments pay for drugs. And it dictated that in the pricing. But in order for them to get this gravy train, they had to agree that if someone doesn't have coverage for a drug and they meet certain income requirements, which are pretty reasonable, that they must be provided the drug at no cost by the manufacturer. Now, no coverage for a drug means the drug is not covered. What it doesn't mean is, gosh, I have a $5,000 deductible and I only have $500 in my checking account, so I can't afford it. That you're still covered for that drug, so you wouldn't qualify for this program. Mm-hmm. Now, what we would do then is we would remove that drug from coverage and then walk the employee through the application process to get the drug mailed to them for free to them, where they were paying $5,000 a year or whatever, and free to the health plan. Now, go ask Express Scripts to remove a drug from the formulary, and they're going to say no, because they get paid every time they fill a drug to the formulary. So in our model, when we have PBMs that are paid in an aligned way, they have no trouble giving us that control. And I'm paid in an aligned way because I want to make that bonus. And I can make that bonus sometimes by just removing one high-cost drug. So again, back to that Upton Sinclair quote, every vendor that we use to build out a health plan, and we use all the same components that every health plan has. There's an administrator, there's insurance for large claims, there's a pharmacy benefit manager, there's some way to price the care, there's medical management. All those things are still in there, but the players that we use, the way that they may get paid, the way that we get paid is aligned with the interest of the plan. And that just dramatically increases the likelihood of those outcomes actually occurring when everyone's paid to achieve those outcomes. So I'm really proud when we get a bonus, and I've never had a client not pay us. They're usually excited to pay us the bonus because we had some really big accomplishments for them. But I think for me, a lot of it is those clinical accomplishments where people have been dealing with chronic migraines and they've been going to the same doctor over and over, and then we get them to a better doctor. One of the things that we really believe in is enhancing primary care. Our healthcare system has intentionally devalued primary care to the point where most people skip over their primary care doctor and go right to the specialist they think they need. But like I said with the back surgeon, the second you get to one of those doctors, their treatment is most likely going to be whatever they specialize in. So if you go to a surgeon, the treatment they're most likely to recommend is surgery. That's not what primary care was supposed to be. And here in the US, we actually spend a much lower percentage of our total spend on primary care than most other developed nations do. So it's the people that have been dealing with multiple chronic conditions, have been unable to cure them. They've just been treating the symptoms over and over. And I'll give you the number one drug that we substantially lower spend on is the number one drug in the US from a revenue perspective, which is Humira. And Humira is an anti-inflammatory. It's one of those biologic injectable drugs. Once you're on it, you can't take any other competitor. You're stuck with that one. But the huge majority of people are needing these anti-inflammatory drugs because of what they're ingesting.
Right.
And when you get to a primary care doctor that can spend 2 or 3 hours with you, like my primary care doctor can, he uncovers so many other things. Asks you about your nutrition, what's in your pantry, where do you shop, culturally, you know, if you're Asian, there's different diets. So like the quality of care, and if I can get my primary care doctor to not just treat the symptoms, but cure the disease, that is the lowest cost environment to get cured, period. And they're incentivized to cure. They're not surgeons. They don't want to do surgery.
And that's actually what I would define. It's not how our system works. It's not ours, but that is how healthcare should be defined, that you are trying to cure the disease and get positive outcomes. And it's just sad that we're so far away from that, all the information that you've provided today. I want to ask, you know, we have a lot of HR listeners, CEOs, CFOs, and I just kind of want to reiterate the numbers and your pride in your bonus structure and how you get paid and the transparency behind that. You just asked, like you mentioned a couple ranges, which I quickly did math, not my strong suit, but I was able to do this one, 30 to 60% possible reduction in costs over a 2-year period. And so as a business leader, I've certainly had P&L responsibility. And if somebody told me I can give you 60% savings, what can you do? How can you reinvest in your business and your people? And what kind of problems? I mean, we all get into a business because we're really passionate about it for the most part and want to do a good job and want to further the cause of what we're working on. And that kind of money is truly revolutionary. It can allow people to grow in ways that they may have not ever viewed possible, or at least certainly not in that time period. So I think it's a huge testament to what you guys are doing. Couple things to wrap up. What does being revolutionary mean to you, David?
I think for me, the revolution occurred when I was no longer being paid by the insurance carriers. And let me tell you the revolution that occurred. It's really simple. Prior to that, in my mind, there was a box of solutions that I pulled from, all of which would pay me, right? I'm not going to work for free. I had employees and, you know, family to feed. So I had this box of solutions that this is what's going to pay me. This is the box I go to. When I got paid directly by the client, and more importantly, aligned, that box completely went away. And how do I solve the problem? Because when I solve their problem, I make more money. And when I solve their problem, I do good for the world. Like I think one of the things that brokers and consultants, it's been lost on them, maybe they never even had it, is I don't think there's another professional that a business employs that not only touches the company as deeply financially as we do, but touches every single employee and family member of that company financially. But more importantly, and I know most brokers take a hands-off approach and they put in Blue Cross and Blue Shield or United, but they're also putting in processes that are driving clinical outcomes too. And that's a huge responsibility, especially when you look at statistics like the #1 cause of bankruptcy in the US is medical bills, and 2/3 of those people had health insurance. That's an awful statistic. So I think, again, there's a lot of really smart business owners. I want you to recognize you may not want to be, you may not have planned to be, you may not realize it, but you're in the healthcare business. When your 3rd or 4th biggest expense is healthcare, you're in that business. And I remember I met with a really large international tire manufacturer. I won't say their name. And they told me when we walked in about how they recently upgraded their trucks to have those wings underneath the flatbed, you know, and they said that it was saving them 2 cents a mile in gas. I said, really? You're saving 2 cents a mile in gas? That's fantastic. What are you doing to save 2 cents a dollar on your health plan? And the answer was nothing. So even though they spent millions and millions of dollars to save 2 cents a mile, they have no idea how to spend any money to save millions and millions and millions of dollars on healthcare. And I believe that if they looked, when I peeled back the onion and I looked, that there's a lot of smarter people out there than I, and they are going to find better ways to do it. They're going to find ways that are more in line with their company's culture. And from an HR perspective, if you're HR, like this might sound, you probably don't fully understand it. I know we didn't go into enough to understand it. And so that lack of fully understanding it brings, oh my gosh, it's different, it's not going to work, or maybe it's going to be a lot of work. But think about this for a minute. let's pretend that there's an employer out there who's paying 75% of the cost, which is a pretty common split. And they have high deductibles and high out-of-pockets. If I'm able to put in a plan where we eliminate those out-of-pockets when employees they have the choice, but they have the option to eliminate those out-of-pockets completely. And if at the same time we cut the costs by 50%, that means the company can now pay 100% of the costs, still be paying less than they were paying before. And the HR person gets to say when they're hiring and recruiting, we pay 100% of healthcare and our plan often has no out-of-pockets. Like, how amazing of an HR message is that? But it takes a couple of years to get there. It does. It's not easy. It's different. But I just think it's completely necessary. And I often find HR is our obstacle to doing this because they don't have P&L insight. They don't have a lot of financial education. That's not what they do. It's not what they went to school for. And so we demand from the get-go CEO or CFO involvement in the decision-making process. Once the decision is made, they can step aside and HR can take over. But this is a financial decision too. It's probably more a financial decision than an HR decision. And I think that that's been lost on it because, HR, CFO says, HR, you handle it. And they're not given a lot of options. It's a Blue Cross, United, Cigna, Aetna. It's 4 options that most people get, and that's it.
Yeah, and just as somebody newer to the industry, I'd say that the amount of knowledge that you need to learn moving into anything insurance related at all is truly astronomical. So I understand the challenge with HR. They are not insurance professionals. They aren't financial professionals. To your point, they don't have P&L. They're there to serve the employees, but they're going to rely heavily on the experts, which again, I'm using my air quotes, the experts that they're working with. And so, pick your resources wisely and ask the right questions. And if you're not liking the response, be willing to change. It can be tremendously advantageous. Going to get into kind of letting everybody know where to find you, best way to reach out for more info. But before I do that, is there any questions that you wish I'd asked? And if so, how would you have answered?
It's a great question. So one question that I can see an employer asking in light of some of the things we just discussed is, okay, great, David, you saved me 50% for a couple of years, but then what? So once we've soaked out all the waste, we then tie our performance inflationary trend, which is typically CPI or below. So I want to give you a quick number. We have a client that's 360 employees. They've been in our model for 4 years. Prior to that, they were with Cigna. So we took just 360 employees. I want you to remember the size of this company. We took what their Cigna had been doing for the 10 years prior, and we trended it out 10 years. Then we took what our plan had been doing for the 4 years so far and trended it out another 6. And we compared the total dollars spent over 10 years in our plan versus what would have been spent in the Cigna plan. The cumulative savings over that 10-year period, all in, for 360 employee company is $72 million. Because once we soak that waste out, if we get down to 50%, and now the number inflates at, let's say, 3%, versus double that number inflating at 9 or 11%, the delta just gets bigger and bigger and bigger as time goes on. Mm-hmm. So we don't save less money as time goes on. We save more money as time goes on. And one of the lines of BS that our industry gives to employers all the time, and this is a game. I want everyone to know this is a game. When your insurance company comes out with a 30% renewal and your broker negotiates that down to 15, you should be pissed. You should say, wait a second, you wanted me to sign 30%? Do you think they're still making money at 15%? Yeah, I bet you they'd be making money at 0% too. But it's a game. And then the broker comes in and says, look, I saved you 15%. No, dude, you cost me 15%. Mm-hmm. We look at savings based on not how much less crappy did we do than you would have done, but how much better do we do? And I want everyone to know that our bonus structure typically doesn't even start unless we lower spend this year by at least 10% over what you spent last year. So
put your money where your mouth is.
That's it. So that's a question that I think some people should ask. But the best place I put a lot of content on LinkedIn. So I would, reach out to me. You can message me through there, or you can just follow along. You can tell I don't have any hesitancy in poking the bears, but I can do that. I can call out Cigna and Express Scripts now because I'm not being paid anything by them. but they hate me. I'm surprised I haven't gotten a cease and desist letter because I've publicly called them out in ways that they have yet to find a way to deny. And I will continue to do it. But I want everyone in their brain to split healthcare and health insurance and recognize that those are two different things. And if you recognize that when you change your health insurance, all you're changing is who's cutting the check and how the price is determined, hopefully that makes it a little less scary or seem a little less risky.
All right, thanks, David. That just made me think of a final question. What's an insult you've received that you're proud of? I assume you have some haters, as you've been clear. So love to hear kind of what's been thrown at you that you actually took as a compliment.
That's a really good question. Most of what they perceive about me just isn't true. And the sad part is that I'm an open book. Not only do I put everything out there that we do, but we have a whole mentorship program where we mentor brokers and consultants around the country on how to build these types of plans for their clients. So a lot of times the compliment I get is just strictly, thank you for giving me the time, or you may not want to share this. The insults I get, they typically don't mean much to me because they're typically not accurate or true. But I'll tell you, I recently put up a post just a week or two ago asking, do you think an employer should consider telling employees that if they're unvaccinated, their plan will not pay any COVID-related charges? And I knew it was a controversial question. I mean, it's become very politically charged, the vaccine and the mask and everything. But 2/3 of people said no. I think that's right. If they are not willing to take a shot to lower their risk of a major claim, then the plan shouldn't pay for them. 33% felt the other way. And of course, it got political, and they said, well, what are you not going to pay for obesity-related expenses for obese people? And I said, listen, that's really different. And this is coming from someone that used to be obese. For me to lose weight is a massive socioeconomic conundrum. For me to get vaccinated is getting a jab in my arm. Like, there's a huge difference between those two things. I would more liken it to smoking. There's a lot of employers out there that charge a smoking surcharge, right? Mm-hmm. We're accustomed to that. So why not charge a COVID surcharge? I mean, Delta just announced they're charging $200 a month more to any employee that's on the plan that's not vaccinated. So, I mean, it's not giving my indication one way or the other, but that brought out a lot of controversy.
Oh, I'm sure it did. But I love personally, I love that you are willing to have these conversations. I think that they need to be had. And from my perspective, just kind of hitting on your point about, letting it roll off your shoulders because they're not true. I would just say again, like my own experience, I was connected to you through a mutual colleague, suggested I follow you on LinkedIn. You were quick to accept it, invite me into your coffee break, call me out and welcome me into it. And then quick to say yes to this. And we don't have a hugely established relationship. So I see nothing but somebody who's really passionate about what they do, about change, and about sharing the knowledge that they have so that everybody can be more successful, more healthy, and have better outcomes. So kudos to you. I think we need more people who are kind of joining the revolution. So I encourage, if you are inspired today, do your research, join the revolution, reach out to David, and let us know if you have any questions. And David, thank you so much. This was a pleasure and very eye-opening. Really appreciate you taking the time to talk with me today.
Thank you so much for having me on, Nikki.
All right. Bye-bye.